All right. I think we might kick into it. We do have quite a lot of content to cover off today, so I want to make sure that we allow enough time to get through everything. Firstly, I just wanted to thank everyone for joining us today for this webinar series. Just so that everyone on the call knows, today's webinar will be recorded and we'll then be making the recording available on the Eagle training website. So you can find it there probably in another couple of days. So today, Ed and I are going to be speaking about ArcGIS and really how that's being used in the health sector. Ed is a solution engineer who's joining us from our Christchurch office. And we're really fortunate today to be joined by Alan Shorey, who's a geospatial analyst at Manatu Haiora, and also Brendan Watkus, who is a delivery lead at GBS and has done some work for the Northern Regional Health Alliance that he's going to speak to today. So welcome, Alan and Brendan, and thank you again for joining us. Over the next hour, we're going to kick off with just an overview of the health sector. Then we're going to be speaking about the geographic approach. And then we're going to be really digging into how the geographic approach is applied within the health sector. We'll be hearing from Alan around some facilities data that is published by Manatu Haiora. Then we're going to be really spending some time looking at specific applications around GIS within the health sector. And then Brendan's going to finish off speaking to a case study using ArcGIS to help solve a problem for the Northern Regional Health Alliance. Then we're going to finish up with a Q&A. So just so everyone is aware, you will see a button at the top of your screen for submitting questions. So I encourage everyone to submit those questions as they come to mind as we walk through today's webinar. Then what we'll do is we'll spend some time at the end addressing as many of those questions as we can in the time that's remaining. All right, so let's get into it. The health sector in New Zealand is really, of course, united in our common goal of achieving better health outcomes across our population and providing services to support this really as effectively and efficiently as possible. Now, the health sector, as we all know, is a complex and dynamic sector with a range of stakeholders across the public and the private sector, including non-government organizations and charities, with some of them operating at a national level, right down to community level organizations as well. Of course, each of these agencies are quite interconnected, and really the goal is how can we as a sector really unite ourselves and deliver outcomes for the communities that we serve. Now, in doing so, of course, there are some shared challenges, which of course are well documented in terms of funding, resourcing, workforce shortages, and of course, as health sector GIS professionals, working with disparate data sources and collection methodologies, working with different systems, and of course, doing so with security top of mind. There's also a lot of shared opportunities across the sector. COVID-19 has really strengthened the connections between agencies and across our community. And technology, which we're going to focus today around ArcGIS, is really a great opportunity for us to address those challenges and deliver to the health outcomes that we all have for lifting the health of all New Zealanders in the most efficient and effective way. So we're going to be focusing on ArcGIS and how ArcGIS can be used to address these challenges within the health sector. GIS, of course, we know is a really powerful tool where we can use geography as that common key to bring together those different data sources in a way that allows us to very intuitively communicate the data, apply analysis processes, and really deliver up the outcomes that we're all looking to achieve within the sector. Now, how is that done? GIS is really a tool that enables what we call the geographic approach. And we're going to be spending some time today digging into the geographic approach and how it's surfaced up within the health sector. It really starts with data, right? How do we collect data and do so in the most effective way possible? And that, as we'll see today, can be done using some publicly available data and layering that on with the data that we have available within each of our agencies. The next step in the geographic approach is really visualizing that data, which, while is, for many of us can seem as quite a simplistic methodology, is really effective. We saw in COVID-19 just the ability to see vaccination rates, for example, on a map was really empowering to us as individuals within the community to understand, for example, vaccination rates within our neighborhood. In the geographic approach, of course, we can go a step further in applying a range of different analysis and modeling techniques that we'll explore today that allow us to look at, how can we allocate resources in the most effective mechanism? Where are hotspots of diseases, for example? These can all be done using a range of really powerful tools available to us within ArcGIS. Once we've done our analysis, we can then use those various scenarios to then present up different scenarios to our decision makers to then enable some really well-informed, data-driven decision making that then of course leads to action, and an action that has been taken using these data-driven visualization and modeling techniques. So the geographic approach really enables different common patterns of use, right? You can be an analyst sitting in your office running these techniques on your PC. You could be a field worker that's accessing maps on your your mobile device, or a decision maker who's looking at dashboards and using those to help inform decision making. And of course, the geographic approach can be surfaced up either as a project, as a platform within your agency, or as a common operating picture that's bringing together different agencies' ArcGIS platforms. It really is quite a dynamic way in how this information can be presented up. So we, as GIS professionals, have a real key role in helping to support the health outcomes. Of course, we understand the data, we understand the tools, and how to best leverage those tools to inform the stakeholders that we work with. So as GIS professionals, it's important to know that when we're working with ArcGIS, we're working with a very secure platform. One important update is that ArcGIS Online is now FedRAMP Moderate certified. This means that there are now 3 times more controls in place than ISO. And this is a real major milestone for agencies to expand their use of ArcGIS Online. And we're already seeing a significant change in the way that agencies use the geospatial capabilities from Esri, with many now going through a new security process and able to host data within ArcGIS Online above just the unclassified data that you may have only been able to work with inside of ArcGIS Online previously. There are some resources that we can make available to you for this process, which I've outlined here. But what I would say is just reach out to your account manager if you want access to these resources and just want support in running through a new security risk assessment for your agency. All right, that's it for me. I'm going to hand over to Ed, and he's going to really dive into the geographic approach and speak to some specific ways in how that can be applied within the health sector. Over to you, Ed.
Thank you, Trish, and kia ora koutou, everybody. Great to have you online. When we were really planning this presentation, we were reviewing all the different use cases that we've experienced and come across that you're doing out there right now across that health life cycle. We were amazed at the diversity and range of different activities that have ArcGIS as maybe a part, or maybe a lot of it is based off using data, products, and capabilities with ArcGIS as that foundational system. So really going through that life cycle of assessing, predicting, understanding, and then hopefully applying really effectively. GIS-powered workflows is something that we get quite excited about. Starting at assessing, really understanding why are things happening in certain places, understanding those factors behind social determinants of health, epidemiological research. We're really lucky to have some really clever people and some world-leading figures in New Zealand doing neat research and have done for some time in most of our universities that power these sort of outputs. Then getting into predicting why are things happening in certain places. So that traditionally comes from that environmental health perspective, GIS being a geographic information system, but really applying that to really big problems that we face on an ongoing level, such as healthcare accessibility, not just now, but into the future. How do we plan for our future population while also servicing the needs of those who need access right now? And then from there, taking that next step and starting to plan out where do we put our resources? Where do we put our resources, then tying into making sure that threats that we face, like epidemiological threats, we have the right locations in the right places to service what that need may be if those things escalate. And then going into the frontline aspect, health education and promotion, making sure we're outsourcing those activities to those who are in the best place to do so, based on what our population makeup is and access to where services are already. And then that goes through that whole cycle of emergency response and disaster management that you interface with different communities for outside just the health sector, but also making sure that we're able to deliver to what we need to within that with patient care and specifically vaccine distribution, which we've seen time and time again as one of those really simple to understand and really effective outputs of ArcGIS. So in terms of stepping through this geographic approach that Trish has walked you through earlier, we wanted to start off with that foundational level. Hopefully you've got a really complex or difficult question that really you need outside capabilities like GIS to really assist you in answering. So how do you build this information in the first place? We're really lucky to be living in a time where we have technology that allows us to easily create data sets and not just easily create and maintain them, but also distribute them outwards. Really, this collaboration by default attitude that we have in New Zealand and what we've seen out of COVID, a lot of the data that people are creating, they're therefore sharing. And by sharing, you're really enabling others to put it to work immediately in the analysis and the monitoring and other outputs that are required for all these different workflows users are doing in this space. So geospatial data in New Zealand really takes multiple different forms across a variety of different platforms. We have a wealth of sources that we can tap into as inputs to our analysis, planning, and decision making that ultimately our products get used for. And what's great about this is This plugs into an international kaupapa called the Living Atlas of the World. So this is an ArcGIS or Esri specific curated resource that doesn't just cover data here in New Zealand or the United States. It's all continents, providing information to really provide this catalog of APIs you can reference that really make it easier for you to get into those more technical or time intensive steps. Eagle recently have released the Content Hub, the ArcGIS Content Hub. So this is a resource, you can see the link down the bottom there, that really allows you to access an interface that's tailored just to understand what's the ArcGIS footprint of sources that you can tap into. What feature layers exist without having to search maybe other forums? This is a channel dedicated to just seeing what's really available. So I encourage you to look into this alongside all the other great resources that we're going to be sharing over the next 40 minutes. One thing that's often underappreciated, but is one of the most important backbones of any content we provide into a GIS is a base map. Because without a base map, we don't have a map or a web map that we can overlay our data on top of. Eagle Technology have a content team dedicated to making sure all of those sources that we were referring to earlier, if appropriate, are sent into these base maps with regular updates. So really just keep this in mind that you've got the building blocks of a base map for not just your organization, but all the other workflows that you power with others. And you can even take these base maps if you wish and customize them and configure them to be the colors that maybe fit in best with the products you're trying to create. But it always comes back to the data. And we realize that for the past couple of years, there have been certain facilities that in order to find them and unpack them, and really start using them in your analysis, OpenStreetMap has been one of those sources that people have pointed towards. And it's great in the sense that we have OpenStreetMap available as a source inside ArcGIS, and with layers that are ready to use that update every 5 minutes that are publicly available. But we can take that one step further, the fact that everyone's publishing and creating content and then sharing it by default really is starting to build this trusted network of sources within every agency that really participate in this space. And I'd like to now pass over to one of the most significant data sets we've seen in this space released in recent times. And I'm now going to pass over to Alan to talk around his case study, a national source of truth for health facilities in New Zealand. Alan.
Thanks, Ed. Yeah, kia ora. I'm Alan, and I'm one of the geospatial analysts at Manatu Hauora, alongside Andy Bartle, who's also in the call. The geospatial function at the Ministry of Health kind of sits under the analytical projects team, and our role is to support regulation and decision making. Because our team's quite small, we also have a community of practice where we meet with Te Whatu Ora and share and collaborate ideas between the two agencies. And I'll run through a quick couple of examples of things we do. So safe area mapping for abortion safe areas, disease mapping and analysis, drive time access analysis, and there's a couple of examples of the outputs to the right-hand side. We also maintain a geospatial dataset, and that's what I'll be explaining today. So what this data is, how you can access it, how we update it, and some of the limitations. Onto the data. We currently manage 6 datasets, so public hospitals, private hospitals, GP practices, rest homes, pharmacies, and blanket locations. We update these approximately every few months. And the source data comes from the facility code table and health cert, which are a list of registered facilities. So we get the raw data from our website, and it's usually in a CSV format and a bit of a mixture of geocoded data and some just address data. So it's not that accessible to people. So our goal was to make this more accessible so people can bring that into their analysis. And I've got the link, sorry, on the previous slide. Health Maps healthnz.maps.arcgis.com, where you can access the data. So now I'll go into explaining how the data is updated. The whole process runs completely within R and interacts with Esri at various points throughout the process. So the first step is to pull in the data directly from the web page. And here we do a little bit of tidying up and formatting the columns to make it all consistent. In the second step, we geocode the data. So we use the tidy geocoder package here, and then call the ArcGIS geocoding API, and that returns the coordinate and a score of how good the geocode match is. And then in the final step is where we upload it to ArcGIS Online. And we do this through some functions which Te Whatu Ora developed. And these functions help us interact with anything on ArcGIS Online. So publishing new layers, updating metadata. And we can do that all sort of through R. And there are a couple of limitations with the data. So the source data is originally developed as a list of registered facilities. So if a business does close, it could still remain on there for some time without actually operating. And there's also different business structures. So one business could have many locations, but with one registered address, so like a chain of businesses. We're also limited a little bit by the accuracy of the geocoding. I guess the good news is the ArcGIS geocoder returns a level of confidence, and we set this quite high so we can manually check back whether there's any missed geocodes and correct this and then hard code that in for the next update. But all these limitations are summarized on the metadata page of the data, so make sure you know the data before you start using it. Sorry, next slide. Yeah, so hopefully that's a useful data set for people to use. And if you have any questions or requests, then you can email us geospatial@health.govt.nz.
Awesome. Thank you very much for that, Alan. And I know it saved many a lot of time publishing this data themselves and hosting it. So thank you to you and the work that you do and your colleagues in order to enable that data set for the rest of us to just pick up and use without having to do all that work ourselves. So the fact that we have data available makes it really interesting, the experience we now have in terms of how we interact with maps. And that whole experience is transformed and this idea of the modern map has sprung up. We realize that modern data is fluid and it comes from all sources. And so at times we have data sets that exist for maybe a short amount of time, but they fill the need of what we need for our analysis processes. Things like locations of interest. That was a data set that emerged and then disappeared, but at the time it existed, it was really integral to the work that people were doing with GIS. So opening up data is this ethical value we all share, and it's excellent seeing the Ministry of Health really demonstrating that through providing this data openly. And really this allows all of us to be able to explore possibilities. What comes together when we start drawing together different layers of information as this insight, and we start to have new discoveries about understanding what's going on in areas that we are focused on. So one of these is a really simple example, the COVID-19 vaccination rates around New Zealand. This was an application that was hosted on the COVID-19 website using data published from the Ministry of Health as a live service. So it allowed people to go in and actually understand the impact or how safe were they in their communities from a vaccination perspective, and maybe inform and drive action to really boost the idea that vaccines at the time were a really sensible thing for people to go and get. But then being able to compare between high geographic levels at a country basis right down to an individual community, but then zoom out and understand the trends. between different areas, who was maybe focused on vaccinating certain groups of the community or certain dosages. So a really complex set of questions that can be answered from just a simple map and a layer on top of a map at that. Only two data sources put together to produce a whole lot of insight. So this then goes into a little bit more advanced, if we want, with the interactive web mapping capabilities that are available in ArcGIS Online and Enterprise, but also in our desktop client and Pro as well. We can now do things that would have been time-consuming cartographic techniques all those years ago, things like layer effects, showing certain layers, filtering other layers on the fly using layer blending, being able to do a whole lot of legend and type grouping that doing that in desktop alone would have maybe taken a couple of hours just to get the ordering right. We're seeing charting and different infographic techniques also brought in to the core capabilities that are available for how you visualize your data. And this just keeps progressing as time goes on. But if you're not able to take advantage of maybe these techniques just yet, here's one technique you definitely will be able to. For those who are maybe creating policy or static maps inside ArcGIS Pro, inside desktop, we now have automatic resizing of layer elements. So if you're needing to create an A4 product, but it's currently in maybe A3 or A2 format, you no longer require manual repositioning of the different elements on the page. This all happens automatically as soon as you click a button. So really the software is becoming smarter for some of these core workflows we still depend upon, allowing you to take all the smart mapping capabilities of online, put them into desktop, but still be able to quickly generate an initial map to produce that insight and understanding. But that's just the tip of the iceberg. We've put layers on top of a map, we've drawn them from sources. The next step is that analysis and modeling step. And this is where in the health sector, we see GIS primarily used for the most extent, really as an analysis and modeling tool. And really bringing the visualization techniques into the analysis is something that ArcGIS is pretty unique for. Once you've framed the problem, posed a question, and explored that content, being able to model iteratively, and then being able to view your result and explore it, and maybe remodel and iterate again, or just go straight to articulating and communicating and sharing that, is something that is really exciting as a GIS analyst, particularly when you produce something that allows you to see what others can't. So some analysis methods that are enabling this for step 2, that iterative modeling, is traditional spatial modeling or geoprocessing that you can see there in the top right-hand corner, stringing together a logical sequence of operations or tools through maybe Model Builder or geoprocessing and Python tools. As Alan spoke to, R and ArcGIS work hand in hand. So for the large amount of the workforce who use R, ArcGIS accepts and is able to read and interoperate with that, as you can see in the bottom right-hand corner. As we see new things emerging, such as machine learning and artificial intelligence, which is being used right now, maybe not for analysis, but for other things that we're using as a sector, remote sensing and image processing is going to become quite exciting. Climate change and environmental health is an emerging area, and as we have more data sets made available that are cost effective, but also ready to use, we're no doubt going to see more and more of that raster modeling process used inside the health space. But we really just wanted to emphasize that Python and R relationship with the platform. Given some of those challenges that Trish presented earlier around we never have enough people, we probably don't have enough time, and funding is always a bit of a challenge. Working smarter, not harder, is where Python and R really come into their own, as you're all aware. Being able to automate and scale those workflows, such as the analysis piece, map production, data publishing, and even administration to enable access to what you're creating, are really those trends that we're seeing Python and R being used for. And these are deployed across a workstation environment, maybe through desktop, through enterprise, and also the cloud. So they're almost client agnostic in a way. And there are a variety of methods that these are being surfaced. We're seeing notebooks used by those who maybe don't have programming experience, but it's a really accessible way to start writing code and automating your processes. For those who are more traditional ArcPy or ArcGIS API for Python users, And those are experiences and methods that people are using to unlock these tools and these new capabilities using a method that's been around for a while. But with third-party Python libraries coming on board and also that R support being enhanced, and we're really seeing a neat pattern of people like the Ministry of Health using these to do tasks that otherwise would have been very time intensive and resource intensive as well from a staffing and system perspective. One of the analysis techniques that we just wanted to quickly mention is the hotspot analysis comparison tool. Being able to do parallel complex analysis methods and then compare the results. This speaks more to maybe our predictive and planning stage of the geographic approach, but a really neat tool just showcasing really complex information but made into a visual output that's easy to understand and interpret. So another one of those key analysis techniques that Alan spoke to, and we'll hear from Brendan taking a bit further later, is that drive time analysis technique. This is really that backbone of many health-related analysis workflows, and we use for identifying coverage, gaps, making sure we're allocating to the right place. We see these outputs often used within the ArcGIS platform, but consider that trend of data as a product, like the facilities layer. Could you generate this data and use it to support other platforms like Microsoft Power BI, Oracle, and Snowflake? Really taking this data beyond the platform to enrich and enhance other systems too. So with all these analysis outputs, one of these really key steps is actually that planning, using the outputs of the analysis and evaluating and comparing them, designing and collaborating to propose and evaluate these alternatives, and asking what is possible when we're using geography as that lens. So just walking through an example, data everyone on this call has is your facility locations, where you operate on the surface of the planet. And as we've heard, you've also got access to open population data through the Living Atlas or one of those many fantastic geographic data portals or geospatial data portals like Coordinates and others. So we've got open population data available at our fingertips. Just putting these on top of each other is insight that you gain immediately. You understand maybe where you operate amongst the social footprint or the demographic footprint in your cities and towns, not just here in New Zealand, but in the South Pacific and wider too. From here, your facility locations and your demographic data, you can run some analysis to understand, okay, who can access these? Where does my drive time footprint cover amongst that population I'm aware of? And the insight you gain is who is underrepresented. We can take this one step further with all this evaluation and actually work out from knowing my coverage, what's the quality for all those who can access it? Who's got that 60-minute commute compared to the majority who have that 5-minute commute? And we'll hear a fantastic application of this shortly from Brendan and the fantastic work they did in the far north. Because really that question is, where should we consider as locations for increasing their outreach that maybe we hadn't considered until we started posing this question using a map. So really this allows us to set up a really strong decision for whoever's having to make that call, really providing that right information at the right time in the right format to the right person. And this all comes down to really clear communication of something that is quite complex. And a neat technique for this is presenting that data inside web maps, which may be consumed inside products like dashboards and story maps. This is all about communicating geography, going beyond that figure 1 static map that we often see in research reports and policy documents. COVID-19 has really taken the rules of cartography and flipped them on their head. We've gone away from primary products for communicating using geography being these paper-based static products to really this modern map, this web map that we can not just view and use through ArcGIS, but also surface in a whole lot of different systems and products. Just showing you a comparison on those two images, we've got a historical example of one of these paper maps, and we're juxtaposing that with a live dynamic web map sitting inside Teams. So really this is aiding a new generation and a new level of decision making that we haven't been able to do historically. So dashboards are a common tool we see for this. There seems to be not much information that you can't put into a dashboard as the general trend. And these are great for being able to provide maps with context, a wrapper, if you like, of numbers, graphs, and charts that really explain what's happening in the map. But these are limited with their narrative ability. This is where we see story maps coming into their own. And we'll see an example of this shortly, really showing how we can take what previously was what we'd put into a static report and really enabling that into a dynamic visual product all can understand. So this was where we start translating into action, really having the storytelling and communication ability from GIS as a really strong output. And this is really focused around creating story maps that inform, engage, and empower, leading to action. And so through our geographic lens, based on what we've found through all these previous steps in the geographic approach, how can we inform you in a way that you understand, you as the audience, you being a busy decision maker, you being someone who maybe isn't aware of the subject matter, but you have to make the call. And just as a short example of this, this is an example that came out in the last couple of weeks from the GeoHealth Laboratory at the Geospatial Research Institute at the University of Canterbury. And this is a story map which really breaks down quite a complex issue, which is vape store accessibility in relation to the underlying population. So this is the trend that I think we're going to see going forward. We're going to see products like this that embed descriptive text, graphs that clearly articulate the problem set and where and what's happening and how it's happening over time, but then bringing the where into it to start to understand that why. So being able to understand the problem at a large scale, communicating and identifying that problem set, but then unpacking it and allowing people to explore how this problem relates to where they are in their area. And so for many organisations who have a footprint or a store within Auckland, or maybe an education facility, being able to put the data in their hands to allow them to take the actions they require, and being able to compare different areas and communicate using this common language of a map. So fantastic example. Once again, a shout out to the GeoHealth Laboratory, Geospatial Research Institute at the University of Canterbury in New Zealand. We're really excited to see this, and it's a brilliant product. Another brilliant example that we've seen recently actually comes from one of our guest presenters, Brendan Woodcliff from GBS, who worked with the Northern Regional Health Alliance around location allocation. So at this point, I'm going to hand over to you, Brendan, to introduce yourself and run through your story.
Hello, thank you very much. Really interesting presentation thus far. Excited to be here. Yes, as you've mentioned, we were approached by the Northern Regional Health Alliance. They look after interests of both of the Auckland, Manukau, Waitemata, and Northern DHBs, who serve a population of roughly 2 million people, and that's across all ethnicities, socioeconomic backgrounds, and in urban and rural landscapes. So they approached us with what was a proof of concept, really. They were on the hunt for a solution that would assist their decision makers in identifying optimal locations for point of care testing facilities that could best serve vulnerable populations and communities. They needed it to be able to illustrate or incorporate population statistics with an emphasis as needed on Maori populations or people living in areas with high deprivation indexes. They needed the model to also take into account the cost implications of access to a facility. So that could be travel time or even the cost of fuel to get there. And then they needed the solution to be easily accessible, shareable, and the decision maker should also be able to interact with the output. So we go to the next slide. So just unpacking, as we unpacked their needs, we found that the location allocation tool really served the purpose perfectly because it chooses the optimal facilities to allocate demand points to in the most efficient way according to specific scenarios or data attributes. The three core geographic data components that were needed for this model were firstly demand points, and these would be representative of the communities that would be accessing the facilities. The facilities themselves would need to be included in the model, and those are broken down into existing facilities because you want to make the most of your existing infrastructure first, and then expand on those. So then identifying the candidate facilities beyond the fringe of the existing facilities and their service areas. And then lastly is the road network, which is more than just lines in the map. You know, the road network that's provided by Eagle, which was very valuable, and that allows us to take into account the impedance or the cost to travel, the distance to travel, etc. So if we go to the next slide. So our first step towards the end goal was the data collection, and so data collection and then creating the analysis layers. So as I've mentioned, we needed to define the demand points geographically. And to do this, we used the census mesh blocks because that gave us a really good indication of where population clusters are placed. And then we enriched that data to include the ethnicity data. And then we included the deprivation index, the deprivation index with a rating from 1 to 10. So a index rating of 10 would be populations with the highest level of deprivation. And this would measure things like security, access to education, employment statistics. So really several different factors were incorporated in the deprivation index. Then we looked at the facilities, and we did also include the facilities register from Ministry of Health. So we did access that data. That was then expanded to include facilities such as schools or marae, because in some cases there were cultural contexts that needed to be looked at, especially in rural areas where there weren't existing medical facilities. There potentially could be a school or a marae that could host a regularly scheduled mobile clinic, say. So we incorporated those. And then the network layer itself, as I mentioned, more than just lines in the map. The network layer that we used included road condition, road hierarchy, speed limits, and even ferry links. So we were able to cater to communities that might have to make use of a ferry for some part of their journey. And then this is just an example of the raw data as we were processing through it. And this process, we ensured that we collaborated as often as we could through discussion and workshops to identify and pull out the categories of facilities and populations that they wanted to include in this proof of concept. So yeah, again, collaboration was really important. The DHB representatives, as I mentioned, took on a very active role in the data collection and processing step. We had several workshops then to look at tweezing out various scenarios that they wanted to try and investigate. So in the one that we have in the slide, this was quite typical individual cases that people came to us with. So here we have an example of a 2-year-old with a urea cycle defect, lives in Cape Reinga, travels approximately 1.5 hours one way to the closest hospital in Kaitaia. She needs frequent monitoring of ammonia by a health professional, but with a single parent and several young siblings, it's difficult for her mother to take her to the hospital. And then expanding on this, they needed to look at 2 potential options to provide a service in this scenario. Firstly, is there a candidate host facility for a mobile clinic because it's in such a rural location? Or is there a facility, say halfway or closer, where they can invest in and build the infrastructure and bring this closer to the communities in need. After working through all the scenarios that were tabled, we found that there was one scenario that we could model that would cover almost all of these requirements, and we settled on the minimum number of facilities approach in the location allocation model, such that as many demand points as possible could be allocated within a 20-minute driving time of a facility. So that was our cutoff point. Anything beyond 20 minutes just wasn't acceptable. And our first run of the model gave us this output. And here we see two very distinct symbologies. We've got the red symbology, which represents the existing facility, which in this case is the Kaitai Hospital. And those red lines show the demand points, those little brown dots, represent communities that are served by the hospital. Each of those communities fall within the 20-minute travel time cutoff for that. And then beyond that, we see the blue points and those blue lines. Those represent the candidate facilities that fall within an optimal geographic location to serve the communities that have been assigned to them through the model. So then if we go to the next slide. So if we look at this slide, so we revisit that initial scenario with the young patient, and we'll see that both options are covered here. We've got potential for in image A, we've got potential for a more permanent facility for new investment, and that would cut down the travel time by about at least half. We're looking at about 40-45 minutes travel time as opposed to 1.5 hours, and that would then also provide a service to the greater community in the area. And then the second option would be, if they really do need a facility that's closer, the next best option would be a school that's been identified as a candidate host facility to host a mobile clinic. And this would be looked at in sort of individual terms or individual case-by-case scenario, because using a school as a host facility for a mobile clinic means that people still have access to running water and ablutions, toileting facilities, and such. Then we go to the next slide. We then needed to touch on the sharing and interaction, because there's no point in having a tool that can't be shared. So what we did was we compiled all the model output into a web map, and we helped the DHBs set up their own AGOL account, and they're now able to access the map, share it in workshops, and look at all of the data in context. We also enriched the map to include the original raw input data, so they can switch those layers on and off for more context. And what was really exciting to see, in one of our feedback workshops, one of the attendees was actually working on trying to expand the network of hepatitis C testing facilities, and they had a spreadsheet of service providers and a report that they were working from. And so we were able to, during the workshop, just convert that spreadsheet into points. We were able to load those features, those points into the map. And if you'd allow me, I can actually share this with you live. So here we're looking at the original output of our network analysis. But if I switch on the layer with the hepatitis C testing facilities, they were quickly and easily able to see where the gaps are across this area. And they were then able to pinpoint the locations that they wanted to investigate as expanding the services to. If we drill down even further, what was really good to see was, even though the model identified certain facilities as being in optimal locations, by adding the original raw data, the decision makers still had the option of, if they didn't want to consider a school as a location, they could look at the next closest option and compare it and see, oh, this is a community midwife, or possibly nearby is a GP practice. So this also just gives them additional context to work with and frees them up when they're making decisions. All right, thank you.
Great. Brendan, thank you so much. I just loved that case study. And it really highlighted how each of the stages of the geographic approach can be applied, with the role of us as geospatial professionals and the knowledge that we have of these really powerful analysis techniques, and how they can be applied, working alongside, stakeholders and those in the sector. So thank you so much.
Thank you.
All right. So just recapping, we spent some time briefly exploring the health sector and the various challenges and opportunities that exist within the sector for us as geographic professionals to apply the geographic approach, with some examples of tools and techniques that allow us to do that in a really engaging way, and hearing from Alan and Brendan around some case studies. We now have some time for some questions and answers. So if you haven't done so, I'd encourage those on the call to think about any questions that they have for Ed or Alan or Brendan, or myself. Ed, can you see those questions?
Yes. We've had a question come through already, which is, will these slides be available following the session?
Yes, I imagine that we'll be making them available on the website.
Yeah, correct. And you've also got the recording as well, so you get the benefit of not just the slides, but also us talking to them if you find that useful.
Yeah, great. If you do want access to the slides, and you're not able to find them on our website in the next couple of days, do get in touch with me. My email, I don't think I've put it in here, but it's just txm@eagle.co.nz, and a number of you will already know me and have my contact details.
Awesome. Thanks for that, Trish. We've got an anonymous question that's come in. Will the facility layers go into the Living Atlas? So I think that might be a question for Alan, if Alan's still on the line. Are there any intentions to publish this data set or get it referenced within the Living Atlas?
I haven't actually thought about that, but I guess if that's possible, then we could do that.
Yeah, Alan, I think what I'll do, I'll put you in touch with Badovane, who I see is on the call. He's the head of our content team here at Eagle, and he can walk you through the process of making that data available into the Living Atlas. So typically what we look for when we're making data available into Esri's Living Atlas is that it's a national data set, and that it's a data set that is published and maintained by an authoritative agency in New Zealand. So we've got those two boxes ticked. So I can chat to you and Andy about that after the call.
Perfect. Well, I know we're at 5 to 12, which is great because I realise some may have 12 o'clock calls they need to go off to. So I think with that, we'll close off the webinar. Feel free to send through questions to Trish, and we can forward them on to Alan and Brendan if you didn't quite catch their emails. But thank you very much for attending and giving up an hour of your time to hear about how ArcGIS is used in health. And we hope you found this useful, and any feedback you have, feel free to send back. We're always trying to make these as engaging and as useful as possible for you on your Thursday afternoons once, or Thursday mornings once a month. But once again, thank you to all our presenters, Brendan, Alan, fantastic work. Keep doing a great job out there for the health sector. And thank you to Trish for coordinating and pulling this all together. So have a good rest of your day, everyone. We'll see you at the next webinar in a month's time.
Thank you very much.
Thanks, guys.